Today, we're talking about amyotrophic lateral sclerosis, or ALS, also called Lou Gehrig's disease. This is a progressive, fatal disorder where motor neurons die off, leading to muscle wasting and eventual paralysis. The exact cause? Still unknown. But we do know this disease hits both the upper and lower motor neurons, and the leading theory involves glutamate toxicity, overexciting nerve cells until they're damaged. ALS affects adults between ages 40 and 60, and while it's rare, it doesn't discriminate. It crosses every race and background. Slightly more men are affected than women. In most cases, the disease is sporadic, meaning it just happens without a family history. But about 5 to 10% of cases are inherited. These familial ALS cases tend to show up earlier, by about 10 years, and the disease progresses faster. So how does ALS actually show up? It depends on which motor neurons are affected. The first signs might be fatigue, muscle cramps, fasciculations, those little twitches you can see under the skin, and progressive muscle weakness. People start losing coordination. If the lower motor neurons in the spinal cord are involved, you'll see weakness and atrophy in the arms, legs, or trunk. Muscles waste away, and the reflexes, they go from normal to hyperactive. You'll often see spasticity too, muscles that are stiff and resistant. Interestingly, the anal and bladder sphincters tend to stay intact. That means bowel and bladder control is usually preserved, even as other systems fail. Now, in about a quarter of patients, the disease starts with muscles controlled by the cranial nerves. That's where things get more serious. Trouble talking, swallowing, and breathing shows up early. A sip of water might come out of someone's nose because their soft palate and upper esophageal muscles are too weak. They might not be able to laugh, cough, or blow their nose. If the bulbar muscles are affected, aspiration becomes a big risk. The voice may sound nasal, speech becomes slurred, and eventually unintelligible. Some patients also experience emotional lability, like sudden laughing or crying. And although ALS was once thought to spare cognitive function, we now know some patients do experience cognitive decline. So what causes ALS? There are a few risk factors to know. Increasing age, a family history, exposure to toxins, smoking, viral infections, and possibly autoimmune mechanisms. How do we diagnose ALS? There's no single test that confirms it. Diagnosis is based on signs and symptoms, supported by tests like electromyography, muscle biopsy, and MRI. These help rule out other causes. MRI may show changes in the corticospinal tracts, and neuropsychological testing can reveal early cognitive changes. As for management, there is no cure, but we do have 2 FDA-approved medications. Riluzole, believed to reduce damage from glutamate. Edaravone, an antioxidant that may slow functional decline. Neither drug stops the disease, but they may slow progression slightly. We also focus on symptom control and quality of life. Spasticity can be treated with baclofen, dantrolene, diazepam. Fatigue might be treated with modafinil, and we also manage pain, drooling, constipation, and depression, which, when untreated, makes the overall experience much worse. Most ALS care happens at home, but patients are hospitalized for complications like pneumonia, malnutrition, or respiratory failure. These can be anticipated and sometimes prevented with the right strategies. Eventually, many patients experience respiratory muscle weakness. When that happens, we consider non-invasive ventilation like BiPAP to support breathing, especially at night. Mechanical ventilation using a trach if needed, though that's a major decision that must be discussed early on. Feeding tubes like PEG, especially before respiratory function drops too low. Decisions about life support need to be made carefully and early. We encourage all patients to create an advance directive so their wishes are clear and their autonomy is respected. ALS may take away muscle strength and speech, but with proper support, we can help patients maintain dignity, communication, and some level of independence for as long as possible. There are also fantastic community resources. The ALS Association provides patient support, education, advocacy, and ongoing research updates. Bottom line, ALS is heartbreaking, but patients deserve care that is proactive, compassionate, and always focused on quality of life.